of liver. The first two images are normal appearances of the liver. This is the left lobe in sagittal view, and this is the right lobe. Right here is the kidney, and the liver is having smooth echo texture. In transverse view of the liver, we can see the blood vessels. The portal vein will have hyperechoic walls, and right here is the inferior vena cava in cross section, and over here these are the hepatic veins. They will not have hyperechoic walls. Here we have the caudate lobe in sagittal view. It should measure 35 millimeters in AP diameter. And this line here is the ligamentum venosum. And over here is the hypertrophy of caudate lobe. You can see it is enlarged. It occurs in conditions such as liver cirrhosis. A simple hepatic cyst will be round, anechoic, and have posterior acoustic enhancement. This cyst is present in the left lobe, and this is a sagittal view. Here is a transverse view of a simple hepatic cyst in the right lobe of the liver. A hydated cyst will have septations. These walls are septations, and they can have echogenic material as well. And they can also have daughter cysts, which means that there could be a cyst such as this one, this cyst within this hydated cyst. A calcified hydated cyst will have hyperechoic calcified rim, and this will lead to posterior shadowing, and internal septations may also be noticed. An abscess can have variable appearances. Mostly it is hypoechoic, but depending on its density it can be hyperechoic, and also it is heterogeneous. But the main feature is that it will have no flow on Doppler, which can distinguish it from other masses. An abscess in the right lobe of liver. This is the transverse view. It is mostly hypoechoic and has heterogeneous areas as well. And when we apply Doppler, it will not have any flow. Hemangiomas are benign liver masses. They are mostly hyperechoic, well defined, and they can be more than one. And they will not have any posterior shadowing. Here you can see one mass here and another mass over here. Here is a sagittal view of the liver showing a hemangioma right here, and when we apply Doppler, it will not have any central flow. Focal nodular hyperplasia is another benign lesion of the liver. This can have variable appearance. It can be isoechoic. It may also be hypoechoic. It has a main feature on Doppler, that is the spoke wheel appearance. When we apply Doppler, we will have this type of flow which resembles a spoke wheel, and this is a feature of focal nodular hyperplasia. A hepatic adenoma is a solitary, well-defined mass. It has variable appearance, but mostly it is hypoechoic. But we cannot confirm these lesions on ultrasound. We need to perform a CT scan. A hepatocellular carcinoma is a malignant lesion of the liver. It has a hypoechoic appearance, and larger masses may have a heterogeneous appearance. but we need to perform a CT scan to have proper diagnosis. This mass is larger than the previous one, and it has somewhat of a heterogeneous appearance. Metastases in the liver are well defined and rounded. They will have a hypoechoic halo. The outer region is hypoechoic and will have a hyperechoic center. This type of appearance is called a target sign or the bullseye appearance. It is very specific to metastatic lesions. This image shows multiple metastatic lesions in the liver, showing us again the target sign. Some metastatic lesions can have cystic components as well. Over here we have the hypoechoic halo and a hyperechoic inner region, followed by a cystic area in this metastatic lesion. This image shows multiple metastatic lesions along with a fatty liver. Now we move on to fatty liver or hepatic steatosis, starting with grade 1, the mildest form of fatty liver. The liver will appear hyperechoic, more hyperechoic as compared to the kidney, but we can see the diaphragm normally, and we can also see the hyperechoic walls of portal vein. In grade 2 steatosis, the echogenicity of the liver is increased, and we cannot see the hyperechoic walls of portal vein. We cannot see that clearly, but we can still see the diaphragm clearly. So this is a feature of grade 2 steatosis. In grade 3 steatosis, there is no visualization of the diaphragm, and overall there is poor visualization of the liver structures such as the vessels. Cirrhosis of the liver is a serious condition in which the liver will be reduced in size and will have surface nodularity, which is the rough surface of the liver, and it will have coarse echotexture, which is also the rough echotexture of the liver, and it may also have ascites, which will be fluid surrounding the liver in the abdominal cavity. Here is another image of a cirrhotic liver showing us surface nodularity and a shrunken liver with coarse echotexture surrounded by ascitic fluid. Portal hypertension can occur due to cirrhosis. In this, the diameter of the portal vein will be more than 13 millimeters, and it will have reduced flow in the intrahepatic portion of the portal vein. It can also have flow reversal on Doppler. Here you can see the blue color, which is suggesting the flow is moving in this direction away from the liver. This is a flow reversal. The viral hepatitis has one classic sign known as starry sky sign. It is also known as centrilobular pattern. You can see echogenic dots in the liver, which resemble about kidney ultrasound reporting. We will see how to write kidney ultrasound reports. This will include findings and impression and will only involve the kidneys. Other organ reports are not included. The first case is of simple renal cyst. The clinical indication in this example is a routine ultrasound. These are the findings. You can write a well-defined anechoic cystic lesion is identified. and then you can write whether it is in the right or left kidney, and after that you can write the size of the cyst. Then you can write the cyst has a smooth border and thin walls, consistent with a simple renal cyst. And then you can write about other abnormalities such as calculi or hydronephrosis. And in the end, you can write about the appearances of the renal cortex and medulla. This is the impression for this example. Findings are consistent with a simple renal cyst. No evidence of associated renal calculi or hydronephrosis. No significant abnormalities identified. Clinical correlation is recommended. It is important to write about clinical correlation because a diagnosis is not only made on ultrasound alone. Our next case is polycystic kidney disease. These are the findings. Both kidneys are enlarged with multiple cystic lesions scattered throughout the renal parenchyma, ranging in size from a few millimeters to several centimeters in diameter. The cysts have thin walls and no solid components. The renal cortex is thinned and the medulla appears echogenic, consistent with chronic kidney disease. So this case of polycystic kidney disease was also associated with chronic kidney disease. In the impression, you can mention the polycystic kidney disease with multiple cystic lesions present in both kidneys. And if there are other abnormalities as well, you can mention them here. And in the end, you can write about clinical correlation. This is a case of kidney stones. The clinical history was flank pain and suspected renal stone. These are the findings. There is evidence of two echogenic foci in the upper pole of the left kidney. Then their measurements are written. There was no associated hydronephrosis or hydroureter in this case, and the right kidney was normal with no evidence of calculi or hydronephrosis, and the renal cortex and medulla appeared normal in both kidneys. In the impression, you can mention the presence of stones and their measurements and in which kidney they are found, and also mention any associated hydronephrosis or hydroureter. After these lines, you can write about the other kidney, and in the end, you must write about clinical correlation. This is a case of staghorn stone. The clinical history was flank pain. You can write the size of the kidney, and then you can write there is evidence of a large echogenic structure in the central region consistent with a staghorn stone. And after that, you can write the size of the stone and its location. And if it is causing hydronephrosis, you can write that. In this case, it was causing moderate to severe hydronephrosis of the entire right kidney. And if there is hydroureter present, you can write about that. Then you can write about the appearance of the other kidney. This is the impression. Findings are consistent with a staghorn stone in the right kidney, causing moderate to severe hydronephrosis of the entire right kidney. There was no associated hydroureter, and the left kidney was normal. Clinical correlation is recommended for appropriate management. This example is of nephrocalcinosis. Both the kidneys are diffusely hyperechoic and they have multiple small calcifications which are seen throughout the renal parenchyma. In this example, the corticomedullary differentiation is preserved. In the impression, you can write findings are consistent with bilateral nephrocalcinosis with multiple small calcifications seen throughout the renal parenchyma. The corticomedullary differentiation is preserved in this case, and there was no associated hydronephrosis. And in the end, it is important to write about clinical correlation. Here is a case of pyelonephritis. The kidney is enlarged and there is increased echogenicity of the renal parenchyma. The renal cortex is thickened and the corticomedullary differentiation is indistinct. Here is the impression. The findings are consistent with right-sided pyelonephritis. In this case, there was increased echogenicity, thickening of renal cortex, and loss of corticomedullary differentiation. This example is of chronic kidney disease. In the findings, both kidneys are small in size and have increased echogenicity of the renal parenchyma. Also, there is poor visualization of medullary pyramids. This is the impression. Findings are consistent with chronic kidney disease, with both kidneys small in size and increased echogenicity of the renal parenchyma. Also, there is poor visualization of medullary pyramids. Here is a case of renal failure. On ultrasound, the findings can be small size of both kidneys with increased echogenicity of the renal parenchyma. The corticomedullary differentiation is lost. In the impression, the findings are consistent with chronic renal failure, with both kidneys small in size, increased echogenicity of the renal parenchyma, and loss of corticomedullary differentiation. Ultrasound alone is not sufficient to diagnose a renal failure, so further evaluation is needed. You must mention this in the report. Now we move on to angiomyolipoma. In this report example, the left kidney measures 10 centimeters in length and appears normal in size and shape. A hyperechoic mass measuring 3.5 centimeters in greatest dimension is seen within the mid portion of the right kidney. The mass has a mixed echogenicity with areas of solid tissue and areas of fat attenuation, and there was no evidence of hydronephrosis or other significant abnormalities in the right kidney, and the left kidney was normal. In the impression, the findings are consistent with an angiomyolipoma in the mid portion of the right kidney. Then its size is written, followed by its echogenicity and appearance, and in the end, clinical correlation and further imaging may be warranted for appropriate management of the angiomyolipoma. This is a case of Wilms tumor. Its usual findings are a large heterogeneous mass with solid and cystic components and is surrounded by a thin capsule. Here is the impression. The findings are consistent with a large heterogeneous mass in the mid portion of the left kidney, measuring 8 centimeters in greatest dimension, with areas of solid and cystic components and a thin capsule, suspicious for Wilms tumor. The findings for renal cell carcinoma usually include a hypoechoic mass with irregular borders and heterogeneous echo texture. These findings are written in the impression. The hypoechoic mass with irregular borders and heterogeneous echo texture. These findings are suspicious for renal cell carcinoma. This report is for cross-fused ectopia. These are the findings. The left kidney is fused with the lower pole of the right kidney, with the left renal pelvis communicating with the fused renal pelvis. The combined kidney measures 11.2 centimeters in length and appears to have a normal echo texture. The right ureter is seen arising from the fused renal pelvis, and the left ureter appears to be absent. These findings are written in the impression, and in the end, the line for clinical correlation is written. It is also important to mention other imaging modalities such as CT or MRI, which are necessary for appropriate management of this congenital anomaly. Here is a report for grade 1 hydronephrosis. There is mild dilatation of the collecting system measuring up to 10 millimeters in diameter. Here is the impression. Findings are consistent with grade 1 hydronephrosis of the right kidney without evidence of calculi, masses, or other focal lesions. In the report of a grade 2 hydronephrosis, you can write moderate dilatation of the collecting system, and you can write the regions involved. Then you can write the measurement of the collecting system. In this example, it was up to 20 millimeters in diameter. Here is the impression. Findings are consistent with grade 2 hydronephrosis of the right kidney without evidence of calculi, masses, or other focal lesions. And you can end the impression by writing about clinical correlation. This is a report for grade 3 hydronephrosis. You can write marked dilatation of the collecting system, and then you can mention the location. Here the collecting system measurement was 30 millimeters in diameter. This is the impression. The findings are consistent with Grade 3 hydronephrosis, and the impression ends with the statement of clinical correlation. In grade 4 hydronephrosis, there is severe dilatation of the collecting system, and there is significant thinning of the renal cortex with loss of normal renal parenchymal thickness, which in this case was less than 5 millimeters in some areas. And here is the impression. Findings are consistent with grade 4 hydronephrosis with significant thinning of the renal cortex. These findings are concerning for obstructive uropathy leading to potential renal damage or renal failure. You must also write about urgent urological intervention because urgent treatment is required.
An ultrasound fluid is black, bone will be white, and other tissues are shades of gray. This is the patient's bladder, and the fetal head is down near the cervix. The position of the fetus doesn't matter at all at this point in time. We often see the fetus completely flip around during the course of the ultrasound. The placenta is on the front side of the uterus. We want to look at that location relative to the cervix. But this early in pregnancy, even if it is low, there's a good chance it'll move higher later in pregnancy. This is the umbilical cord connecting to the placenta. We check to make sure the attachment is normal. When we look closely at the umbilical cord, we'll see 2 small black circles and 1 black stripe. Those are the 3 blood vessels in the cord, which is the correct number to have. We want to look closely at some structures inside the brain. The bright area here is the choroid plexus, the part of the brain that makes spinal fluid. This black area next to it is the collection of spinal fluid in the brain. We measure it to make sure there isn't hydrocephaly or too much fluid in the brain. We also look at this structure in the back of the brain, the cerebellum. It looks like 2 balls stacked on top of each other. For years, all we did was measure it for growth, but we now know the shape may be changed if the baby has a neural tube defect. So looking at this area helps us detect spina bifida. In this view, we also measure the thickness of the skin at the back of the neck. It can be increased in some chromosome abnormalities like Down syndrome. Here we're looking directly at the face, which looks more like a skull. There just isn't much fat yet on the face. Within the eye socket, you can see something that looks like a bubble. It's the lens of the eye. We also want to look at the lips and nose, which are behind the baby's hands. You can see the nostrils appear black because they fill with amniotic fluid. If there's a gap in the lip, a cleft lip, it also fills with fluid and will appear black, so you don't see the nice gray outline of the upper lip. The profile is good to look at for a couple of reasons. First, it's a pretty image that most people can easily recognize. But more importantly, there are times when the chin is too small, which can potentially cause problems for the baby with breathing in the delivery room. We want to see the nose, the lips, and the chin in a nice straight line. This is the spine. We look at the region of the neck, the middle of the back, and all the way down to the sacrum or tailbone where it comes to a V. These views help us detect spina bifida. You can also see the ribs coming off the back. With the spine up towards us, we can also see some of the big blood vessels in the baby, like the aortic arch, the black candy cane-shaped structure in the chest. The heart is one of the most important organs that we look at during an ultrasound. It appears black because blood inside the fetus is really just another kind of fluid. That allows us to see the 4 chambers of the heart valves opening and closing, and the blood vessels leaving the heart. There's a hole here between the right and left sides of the heart. It allows oxygenated blood to take a shortcut from the right side of the heart to the left side and bypass the lungs since oxygen is being provided through the umbilical cord. That hole will close after a baby is born. These colors represent blood flow in the heart and help us to see that both sides of the heart have developed normally and are being filled with blood. The kidneys sit next to the spine and are hard for me to point out to people and show them that they're normal. Here we're looking at a cross-section of the abdomen at the level of the waist. The black dot is the baby's stomach, and it shows up as black because it has fluid in it. The fluid is amniotic fluid, which the baby has swallowed. So seeing it there tells me that the baby is swallowing, which is an activity that should be happening. And since the fluid makes it down into the abdomen after the baby swallows, we know it is unlikely that there is a blockage in the baby's esophagus. Looking further down, we see these little lines. That's where the umbilical cord is actually attaching to the baby's abdomen, so the future site of the belly button. We check to make sure that that part of the abdominal wall has developed normally. And finally, all the way down in the baby's pelvis, we see another black dot, which is the baby's bladder. That tells us that the kidneys, which earlier we saw appear normal, are functioning and producing urine. Here are the baby's legs. They are extended and we see both of them moving. I also want to look at the position of the feet coming off at the ankles and make sure they're nice and straight with no evidence of a clubbed foot. That's where the foot is turned in or out. And finally, these are the bottoms of both feet, like footprints. We're at the end of our head-to-toe look at your baby's ultrasound, and I hope you've learned a little more about what that ultrasound